So, first of all, urinary tract lesions are relatively common. And I would like to immediately say that we will be focusing on obstructive lesions. I mean, non-obstructive lesions are probably not the field of fetal therapy. You have to remember that a number of these will have associated problems, and you have to rule that always out. You can have obstructive uropathy early in gestation. In that paper from Sabir that described that first, it was already clear. But we now know, and that is confirmed in different studies, that an early onset megacystis either points to a chromosomal problem, 21 or 18 preferentially, and if it is mild, it will usually disappear. If it is severe, it's going to stay there. Later in pregnancy is more the typical patient that you will be confronted with. And this is the typical image of a keyhole sign, and what you cannot see here is that there is no fluid. What we are mainly talking about are these patients, the males. And the acronym LUTO actually covers posterior urethral valves and atresia and perhaps a number of anomalies that we have not understood yet, but that are obstructive. You can have non-obstructive similar images, but in females that are part of other conditions. So we have, what you have to understand is, of course, that this very impressive image gives lead to two problems. Obstruction causes renal developmental changes and renal impairment. But if there is persistent oligohydramnios, you will also have lethal pulmonary hypoplasia. Then you have two problems. Of course, you can have also orthopedic problems. The ultrasound features are very easy to recognize. You see lower urinary tract obstruction, ureters that are larger, and then you can have different. You can have enlarged higher urinary, the upper urinary ways, but you can also have secondary damage into the kidneys that to some extent is already predicting whether there is renal damage. And as you see here, it's not a very good feature, but when you have dysplasia, which is seen by marginal little cysts, as well as change in echogenicity, is more or less predicting already renal failure. Now, the problem is patient selection indeed. When we see these end-stage ultrasound features, in a way it's already too late to salvage the kidneys. And we have tried, like many others, by measuring the end product of the kidneys, looking at the urine. And the urine, as you know, is an ultrafiltrate, but then there is an active process that changes the composition of that ultrafiltrate, and normal urine is hypotonic. So if you have hypertonic urine, we know that there is already renal damage. Now, another thing you have to realize is when you tap urine, that you are looking at urine that is there already for days. And for that reason, the group of Mark Johnson proposed to do serial vesicocentesis, in which the second, but mainly the third sample would be the most representative one. Most of us use a panel of electrolytes in urine that I will show in a second. Some of us use serum beta-2 microglobulin. Others use it in the urine. But as I will show at the end, nobody really knows what the appropriate criteria are. But in that review, I mean, these numbers are more or less what you find consistent. Sodium, osmolarity, calcium, here you see beta-2 microglobulin. I mean, you see these cutoff values that are compatible with maintained or preserved renal function. Our way to look at things is try to find out first, when there is urinary tract obstruction, try out to find out first whether there are structural problems. Occasionally we do amnioinfusion to investigate the fetus better. And you may also need it to turn it around to put in a bladder catheter. So when there are associated anomalies, we will not go on further, but when it is normal and we have a normal karyotype, we wait for that. We will do serial urine tests. We also do a fetal blood serum because we are for a research reasons to correlate the ultrafiltrate with the serum levels. And when there is poor renal function, as well as there are associated anomalies, we will decline fetal intervention. For the other two, we may consider bladder derivation, not only a shunt, but here the answer is different. For a baby with normal function, we are doing this to try to salvage the kidneys. But those that already have a moderate function, you can still justify to do your intervention to avoid lung hypoplasia. But it's a complete different picture, and the patient has to know that. The rationale for bladder reversal of obstruction is that it has been shown in experiments that it more or less salvages renal function. There is no good experimental evidence that you get normal kidney function afterwards. So what can we do? Historically, the first thing that was done was open surgery. They have done one vesicostomy and abandoned it for obvious reasons. What we have been doing all for ages was vesicoamniotic shunt, and on the field now is the use of fetoscopy to explore the airways and open the urethra. This is a historical picture from that first open surgery ever. Most of us know these catheters, these pigtail catheters. Most of us were trained with this one. This is the Harrison catheter, a bit smaller. They have the name to be dislodging a little bit earlier. They are 1 millimeter finer in diameter. There is another Japanese one. I cannot show you an example because we could not buy it anymore since 2 years. And these are the introduction sets that are on the market. Very straightforward procedure: fetal anesthesia, fetal immobilization, and insertion under ultrasound. Technically, you have to try to avoid, of course, the lifelines of the baby because they really run on the bladder surface. And you have to try to insert the catheter as low as possible because as the bladder will empty, otherwise it will fall off the catheter. It is a procedure that has complications. Most of us think then about ruptured membranes, secondary infection, but you can traumatize the baby, you can cause fetal ascites, and the main problem is dislodgement of the catheter. So, as you see, if you would insert the catheter here, coming from above, if the bladder empties, the catheter will fall out of the bladder. This will not happen here. Shunting is a ultrasound-guided procedure. There is nothing fetoscopic into it, and it's aiming you have to live with the position of the baby. Sorry for that. What you have to keep in mind is that indeed it may have complications. I mean, look, this is here a bladder shunt. This is a slide that I got from the people in Leiden. This baby had gastroschisis, iatrogenic. But the main problem is ascites and, of course, dislodgement. These are the long-term outcomes of shunting, and they are not as good as we usually pretend to think. These are the survival rates for these 4 series, but what we are more interested in, what are the number of patients that have normal renal function later in life? So that means a glomerular filtration rate above 70 milliliters per minute. And that's only 1 in 2. And about 1 in 3 will have renal failure and 1 in 5 will have a kidney transplant. We do not necessarily call that success. Long-term outcomes, this is a study from Jean-Marc Billard. It's the only study that has looked at the long-term quality of life. Same numbers, 1 in 2 normal renal function, 1 in 3 having transplants, normal neurological development, 1 in 3 has abnormal bladder function, but this is the most important. Despite that, only 1 in 2 has a normal renal function. The quality of life of these patients, perceived by themselves, is completely within the normal range. This means that these patients find that despite these chronic problems they have, they still are extremely happy with their quality of life. And that's an important message as well. Now for the cowboys, we have our tools. Can we do fetoscopy? This is a fetoscopy being done at our unit to look at a bladder atresia, actually. This is the equipment you use. This is the smaller fetoscopic sets. And the dream is that we convert a diagnostic procedure, because we really want to explore the urethra, into a therapeutic one by either ablate the valves, blow them up, catheterize them, stent the urethra. Anything you name is open for suggestion at this moment, because nobody knows what this kind of therapy will give. This is from Rodrigo Riwano's paper from Brazil, your neighbors, where he explained how you have to do this. You really have to see into the urethra and you come from there. Actually, our instruments are not good for it. We have to bend them and we always nearly see it, but not always perfect. And you can see babies that have a valve or a complete atresia, or some babies just have a normal urethra and a prune belly syndrome and are not really obstructive. And when you look at his results, there were 12 patients that he managed expectantly because they had poor renal function, 11 actively treated by fetal cystoscopy, and here he shows what we already know, that luto does not equal posterior urethral valves. In 1 out of 3 there is urethral atresia, which is something different to treat after birth. But what he showed is that in the cystoscopy group, he had a better outcome in utero when he sampled the urine at 26 weeks, as well as after birth, both in terms of renal function as well as survival. But this study is extremely biased because the case selection prior to the cystoscopy was already suggesting that this would that. So you cannot conclude that cystoscopy improves the outcome, but that the case selection was done properly. So it is an investigational procedure, but I am sure you will hear me more from it in the years to come, particularly from this side of the world. So I would say for lower urinary tract obstruction, please remember, rule out associated problems. You have to realize that it's all about saving the renal function as well as the pulmonary function, and that's a choice the patient will make. We have no good criteria for assessing renal function. Fetal cystoscopy is something new, but there is certainly nothing wrong with doing a bladder shunt. At this moment, it's still the standard. You must realize that this is the common denominator. We are not able to prove that the baby still has normal function. And you can see that in that paper. This is a review paper from the group in Birmingham, and it concluded that all operators must know we cannot properly select the patient, because all these diagnostic tests, the ultrasound features, the presence of oligohydramnios, the gestational age, but also the electrolytes, which I didn't show, are not doing a perfect predictive job. I thank you for your attention.
I saw that you passed the catheter through the placenta. In the Harrison catheter, how many is the mortality or morbidity that you have when you use the catheter through the placenta?
We try to avoid the placenta. In that clip, we were just on the border of the placenta. There was no placental hemorrhage. But if you would go through the placenta with for a Harrison catheter, it's 7 French. For a rocket catheter, it's 10 French. You will have significant placental hemorrhage. Whether this is lethal, that's a matter of luck, but it certainly can be lethal. So we try to avoid it, and sometimes we cannot do anything else than do an amnioinfusion and hope we can turn the baby towards us. But many of them are in a fixed position and you will have to accept them.
Doctor, ¿con qué frecuencia el feto se retira del catéter o se lo extrae de la piel y qué estrategia utilizan para tratar de prevenir lo que se retire el catéter de derivación?
The incidence of dislodgement of the catheter, whether it is by the baby or by the operator, because that happens as well, is between 10 and 20% in most serious. It is higher with the Harrison catheter. It is higher. That has a bit of lesser retention, and when you have the coil in your hand, you can understand why that is. But they are also used earlier, so they have more chance to get dislodged, of course. It's something we live with, and we just reinsert one.
¿Alguna otra pregunta, doctora?
Talking about cystoscopic, is there any possibility of stenosis post-procedure? Stenosis of urethra?
Well, I must say that at this moment, there are no proper surgical techniques described. I mean, it's trial and error. Most of us, when we think we have a valve, we would try to either guide a guide wire through it, or hydroablate it, which is pressure, or use a laser fiber. But you must remember, if you use a laser fiber, you can destroy that pelvic floor. Huh? I mean, this is something we really don't know. The main value is in the diagnosis, I think. If you have urethral atresia, many parents just don't want to go on with fetal therapy, at least with us.